Good morning, everybody. Really nice to have your company today. A very special roundtable discussion today. The point of roundtable, if you haven't actually encountered us before, so this is part of an initiative run by Menopause Experts Group, and the roundtable itself. There are almost a committee of us around the table, of some 30 plus, mostly women. But obviously we have our occasional token male who likes to come in and join us when we talk about things that are women's health related. The reason why we set up the Menopause Pro Roundtable is really to get conversations out there into the mainstream, conversations that we may not ordinarily be talking about, and topics of discussion that won't touch us all individually, but as a collective absolutely do. And so I'm really, really proud of this roundtable, especially because we're going to be focused on early menopause, endometriosis, and for those of you who are professionally working in this business, of course, you'll see that PCOS has recently been changed to PMOS. So we're going to be talking about that today. I've got three great speakers lined up, covering a variety of topics, and I'll be welcoming them individually as we go through. We normally last about 90 minutes. So if you can stay, you'll probably be wriggling in your seats by the time you get to 90 minutes, but that usually gives us a good amount of time to cover what it is that we really do want to cover as part of this initiative. So it's really lovely to have your company. So let me just talk about the topics then that we're going to be covering and a few stats around that. Now we've got Dr. Anita Sharma with us, who's our first speaker on the roundtable this morning, and she's going to be enlightening us about endometriosis. Now, this is a topic of conversation that within our champion network is being discussed very openly and regularly. And we were just saying actually before we came on that I'm seeing, and I'm sure that this is more about awareness, but actually statistically more and more women are experiencing endometriosis. I think more and more women are feeling able to come forward to talk about what's happening to them, but we know that there's a considerable amount of both physical pain and emotional and psychological pain that goes with that. But the stats are around 1.5 million women in the UK experiencing endometriosis, and of course they're only the ones that have come forward, and we know that a lot of women experience a huge amount of complex issues without understanding or knowing or discussing, and they'll sit in silence and suffer very quietly. So that's the point of these style round tables, because you never know, it might be that this triggers an open conversation for a woman with her GP or with another healthcare professional, and that could be life-changing for her. So we'll definitely be really, really enjoying the conversation with Anita. Now, if I just to give you a little bit of a brief overview of Anita and all of her wonderful experience. So she's going to kick off this discussion. Dr. Anita Sharma, she's joined us. She's a GP and is specialising in gynaecology. She's also a GP appraiser for NHS England. She's the chair of the Women's Doctors Forum, which is called BIDA, BIDA, and the chair and founder of Endometriosis Awareness up in the north, I believe, Anita, the North Charity. She's made an exceptional contribution to women's health in primary care in particular, helping improve the understanding of endometriosis and the importance of early recognition and better support. Anita is also the author of a book called Endometriosis in Primary Care. It's a practical guide, and the proceeds from her book are going to the University of Manchester for research. She has another book out as well, Gynae in Primary Care, and she won first prize at the BMA Medical Book Awards, which is just brilliant. A remarkable recognition of her work. And Anita, it's lovely to have you, and thank you so much for sparing your time on a weekend as well. For those of you who don't fully understand what exactly endometriosis is, and why it can be so difficult to recognize and diagnose. I'm going to ask that question to Anita as she says hi to us this morning. Hi, Anita. You're on mute.
Hi, morning everyone. So, endometriosis, relatively common, potentially debilitating condition affecting, like you said, 1 in 10 women of reproductive age group, and those assigned female at birth. Simply not acceptable at the moment. 1.5 million women in UK are suffering from it. There is no other medical condition where 1.5 million people suffer from it. Oh no, sorry, I'm wrong. Yes, there are conditions like dementia, learning disability, Huntington's chorea, but in that situation, there are both men and women. Here, it's only women. So it's a condition defined by the presence of endometrial-like tissues outside the womb. So that causes a chronic inflammatory reaction, scar tissue, and adhesions. There are several types which have been described. Superficial endometriosis, which is in the pelvic peritoneum, cystic ovarian, which goes in the ovaries, deep endometriosis, which goes in the bladder, bowel, ureter, sigmoid colon, and rare cases outside the pelvis. I never knew when I wrote my book, first book, that it can spread to the lungs, liver, and brain. At the moment, I've got 2 patients whose endometriosis has spread to the lungs and they're coughing out blood. Why? Because there is a delay in diagnosis, delay in the management. And like you said before, 1.5 million, 27 is the average age when a diagnosis is made. Simply not acceptable. So,
Wow.
yeah.
Wow. I mean, it's quite staggering, and that's what I love about this roundtable. You know, inflammation of the lining, the endometrial. We kind of know that.
I can't hear you.
Has my voice gone off? Am I
No,
back again?
yeah.
It's the complexity of endometriosis that I think most of us really want to understand. And I would never have considered that it would spread to the lungs, for
Yes.
example, as you just said. Um, so, why do you think so many women and girls then experience these long delays before? I mean, you said the average age is about 27 before diagnosis. Why do you think it takes so long to receive that diagnosis?
Yeah. So when the NICE guidelines was published first in 2017, I was a member, GP member, and it was taking 8 years to get the diagnosis. Now the new NICE guidelines published in November 2024, they are saying it's taking 9 years and 4 months to get a diagnosis. In my area of North, it's taking 11 years to get the diagnosis. So why it's taking so long? I think one is from patient perspective, lack of awareness of symptoms. They do not think that the painful, heavy period can be abnormal. And then stigma associated with discussing painful sexual intercourse, especially in ethnic minority. They would not see the GP, or maybe their family won't let them. So I'm looking into it in my area. And then is primary care lack of knowledge. GPs are not aware of endometriosis. I was a gynae triager in my area, did that work for 7 years. And that meant I went through all the GP referrals, gynae referrals, before they went to the primary care. And they were so inappropriate referrals because I knew they'll get rejected. So we need to raise the education of primary care. Another thing about primary care, what I'm saying is now in a GP surgery, we've got so many allied healthcare professionals. We've got practice nurse, A and B, physician associates, pharmacists, they all are seeing patients. So they have to be educated as well. And then the third thing I would say is lack of secondary care specialists. There was a report published, NCE Pod, that was about 2 years ago. That is the National Confidential Inquiry about Patient Outcome and Death. That report also said that 50% of secondary care thought that the painful period is normal, and again, not acceptable. The new NICE guidelines says that all the suspected endometriotic patients should be referred to the specialist endometriotic center. All the primary care do not know what a specialist endometriosis center is, where they are based, what do they deliver. So it's not only the patient, the primary care, the secondary care, everyone, why there is a delay.
Yeah, it's quite horrifying actually when you put the statistics out there and understanding the pain that this causes women. And but as you rightly said, and it's only been a relatively new topic of conversation, and clinicians like yourself bringing attention and awareness to heavy periods and heavy bleeding, because most of us will have grown up just being told that's it, we just experience heavy periods. I'm one of them. Always had very heavy periods, sometimes irregular when I was younger, and then you just kind of get on with it, don't you? As women, I think if we're told, oh, that's normal, then we just know that that's part of us and part of being female, and we have heavy periods. But we now know that that's not normal. It's common, but it's not normal.
Yeah, absolutely right. Yeah.
So, how does this impact then women? Because we know it's not just pain. We know that this impacts them across their work lives. It impacts fertility. It impacts their mental health, their emotional state, and their quality of life, doesn't it?
Yes. Yes. Yeah,
So,
absolutely. Yeah. So it's not
explain the
only, like you
reasons why.
said, it's not only the physical health, but also mental, emotional, psychological, sexual, and psychosexual well-being. They all get affected. Now, in my area of North, I'm seeing more women who are self-harming because of delay in diagnosis, because they can't get pregnant, because of repeated miscarriages. So they are being abused at home. Now I'm also involved with Uni of Manchester and a self-harm project. So the self-harm project is like a knowledge support system. So there will be a tool on a GP practice system, so that when a patient presents with A, B, and C, they would know exactly what's to be done, where that patient should be referred, and why the referral should be done. So there are so many things about endometriosis that's not been recognized. Like I said, if 27 is the average age, 60% are not able to, 60% see 3 or more clinicians, 68% misdiagnosis, and 80% can't able to do their work, and then they've been made redundant. So I'm also learning more and more as I've got involved with the endometriosis, because women have to be empowered. Primary care has to be empowered. Secondary care has to listen to us that why there is delay, and government has to listen to us. Government is ignoring. The one thing which I would say here is gynae has always been ignored. You take it endometriosis, menopause, infertility, repeated miscarriages. Why? Because there is no QOF, quality outcome framework, in any of the gynecological areas. So if I provide heart failure management, asthma, COPD, I get paid, and I can have a nurse, and I still get money in my pocket as a GP. But if I see any of the women's health, there is no co-op in any of the gynecological areas, so GPs won't update themselves because there is no money involved. And that is what we are saying to the government, Department of Health, that QOF has to be introduced in all gynecological areas.
Yeah, wow. I mean, is there a message that you'd like to put out to GPs, and what can GPs, as our first line, how should GPs be approaching this, and what can they do about this?
So every GP should have an educational session in the surgery. As an appraiser now, I'm seeing so many complaints against GPs because there was delay in the diagnosis. If I go through the list, there will be no time left for my presentation. So they should have a quality improvement in their practice, which should be attended by all the service providers. And when I say, why don't you do it? Oh, Anita, we've got other things to address, COPD, asthma, because we can make money. So unless this gets addressed, QOF, I do not think the primary care will spend their time or energy. So I'm involved with my local MP. We went to the House of Commons and I did a presentation. So I talked about QOF and they were, sorry, don't record that, clueless about QOF. What is QOF? So I said this has to be introduced in women's health. Otherwise, the women's health will not improve. And we all know if a woman is not well, the whole household suffers, the workplace suffers, the community suffers, and our nation is suffering as well. So if I say 12.5 billion being spent on women's health, that money can be easily saved, can be easily. But there you go.
Yeah. No, I totally understand what you're saying. And for somebody who's experiencing difficulties and perhaps feel as if they're being stonewalled, what would be the advice to escalate and to get further investigations?
Yeah. So like you said, GPs will dismiss their symptoms. Oh, painful period is normal. So that's what I'm doing now. I go to various community centers and I empower these women that do not suffer in silence. So if you've got painful, heavy period, debilitating, you can't get out of bed, you can't go to work, the ordinary painkillers do not work, then do not suffer in silence. Just say that, yes, this is not right, and I want to be investigated further. Another thing I've done, Debbie, I've made a 6P poster for GP surgeries, and I've distributed to various GP surgeries. So 6P means painful irregular period, painful sexual intercourse, painful bowel movement, painful when urinating, and difficulty getting pregnant. So any of these symptomatology goes in favor of, could it be endo? So GPs, now the new NICE guidelines clearly say that any of these symptomatology, you have to refer that patient for investigation, abdominal scan or a transvaginal scan, and do the follow-up in 3 months. But is it happening? It still isn't happening.
No, I think that's so important, these conversations, because it will perhaps give women the confidence to just push for further investigation, as we, most of us will have experienced having to be our own advocate when talking to a GP. But unless you have knowledge, unless you have that confidence and you're empowered to do so, most women just won't. They won't open up or talk about, especially a sensitive conversation about anything that's below the belt. We just don't want to talk about it, and particularly if we have male GPs as well. Yes, it can be very uncomfortable. It's talked about as a reproductive health issue, is endometriosis, so we can kind of see why. But don't you think it's better to be understood as a whole body experience, a whole body, and of course there's inflammatory, and we're seeing a lot of evidence actually in research coming through from the GLP-1s. Just throwing that in there, I'm reading quite a lot at the moment, which is encouraging. Not that I'm somebody that pushes for pharmaceutical at all. I think we should always look at diet, lifestyle and stress factors, but there's some very, very interesting research coming out now about GLP-1, and I'm pretty sure that that's mostly to do with the fact that our bodies are so inflamed most of the time because of our stress, diet, lifestyle, which is dramatically different than it was, 40 or 50 years ago. And the GLP-1 injections at the moment seem to be reducing a huge amount of that inflammation. And I think that just by default, that is impacting a lot of, we just keep the conversation about women's health, but a lot of impactful women's health diseases and areas of concern. What are your thoughts on that? Do you have a similar?
I absolutely agree with you. We need more research on, because at the moment there is no definitive treatment which works for endometriosis. So yes, this is one. Then we still haven't got an early diagnostic test. That's also an area where we should be focusing, because at the moment the only diagnostic is laparoscopy and histology, and the waiting list for laparoscopy is 8 months. Now I'm involved with NICE, so we are doing technology appraisal for a blood test. We need a blood test which can detect endometriosis. How long would it take? No idea. They are looking into a saliva test. Oxford is involved with that. So saliva detects the mRNA. And again, how long would that take? I do not know. Then they're talking about the myometrial activity, like we've got an ECG. So they've got an electroviscerogram, which will detect the electronic activity of the myometrium. How long would that take? No idea. Like you said, GLP-1 is another one. So when it comes to research for women's health, there is no money. There is no money for research. There is no funding. So it's all the pharmaceutical companies that we are relying upon. GLP-1 is one. Then we've got this ultrasound, another pharmaceutical company. But it just takes ages. It takes years and years and years. And women's health, again, I'm repeating myself, is always been ignored. Always been ignored. Yes.
Yes, I think we
No,
all.
we women live longer than men, but we live in poor health. All our healthcare system has been designed by men for men. Research, clinical trial, education, you name it, all focusing towards women, men's health. Yeah.
Yeah. I mean, when you say that to women who don't work in our field, they're not associated with women's health as a sector, I think a lot of women are really shocked.
Yes.
I think that they're totally oblivious to the fact that actually women's health research hasn't existed.
So I have involved men as well. So the sufferers, endometriotic sufferers, I involve their husband, stroke partners, and their dad as well. So whenever I do a presentation for a GP, I let the endometriosis, the sufferers tell the story, and then I will say why her dad was shouting at her because she couldn't get out of bed to go to school, do the homework, failed all her exam. Why the husband and partner, I took them to the House of Commons as well. I said, go on, stand up and share your story, what you saw in her and why you dismissed the symptoms. So I think it's making an impact. But again, in Black and minority ethnic, there the men will not come forward. They always feel it's women's fault. Yeah, I'm trying my best to empower them as well. Yeah.
Yeah, I mean it's a huge melting pot actually for us, isn't it? Because I was only speaking yesterday about women women who grow older, who are poor, in poverty, are treated so much. We know that they're treated badly. So women without means, financial means, are treated badly as we age. And so it's actually not just research. We need money in the hands of women so that we can actually build and use techniques to bring things to the market that actually help, because we can't wait for governments, can we? Because as you said, it takes so long, many years, sometimes decades, to actually bring about these changes. And so, this is why our movement's so important, is that we need to advocate for ourselves now. We can't wait for things to catch up because we simply don't have time.
Yeah, we waited long enough. We waited long enough now. And like you said very nicely, we can't wait any longer now. So together, if we work together, we can make a difference to women's lives. And like I said, our nation is suffering because there's so many women suffering with menopausal symptoms who've been made redundant. They can contribute. They can contribute. I provided support in my practice to menopausal women because I was one of them. Same is endometriotic. If you're suffering with debilitating pain, rather than saying, thank you very much, we don't need you, she can work from home. She can work from home. Give her 2 or 3 days rest and she will deliver more. But not happening. I think unless we get QOF, that is the one major point, quality outcome framework in the gynecological areas, the service provision from the primary care will not improve, will not improve.
Oh, thank goodness for spokespeople like you. So let's just talk about your book. So Endometriosis in Primary Care, written for GPs primarily. So has this book, I mean, is it out there? Are they picking it up and reading it? We know what GPs are like. They haven't got any time. You just hope that they can actually just listen to a podcast version or something like that, because they won't have time to sit and read a book. But this information is critical. It's crucial, isn't it, for GPs?
Yeah,
So
definitely.
tell us about your book.
So the book is aimed for primary care, like you said. Also, it's got a chapter for secondary care, surgical intervention. Andrew Horn, you all must have heard about him. And then my local consultant, gynecologist Kavita Verma, she contributed. So there's a chapter on surgical management as well. So for secondary care too, there's a chapter for patient, because living with endometriosis is a chapter contributed by 3 patients and their family members. So I say read, go through it and see what she's gone through, what her parents thought about her, what her partner thought about her, so you can improve your knowledge about it. But yes, mainly for primary care. So there are nice guidelines, what else should be done. So your question, my book, has it made any difference in the provision of endometriotic services?
It can do if enough people read it, I'm guessing.
Yeah. But enough people won't buy it. And I always force them. I said, money is going towards research. So Professor Marshall is involved with the research. They are developing hydrogel. Hydrogel is something which delivers the drug onto the endometriotic deposits, and those deposits disappear, and hydrogel gets excreted in the urine, so no side effect. So rather than going every time and getting those lesions burnt, if we have hydrogel, the deposits will disappear and there will be no spread of endometriosis.
Wow.
So
We just hope that progress continues and continues. Now, just to finish up, because anybody who's listening to this on the recording, and this might just touch a nerve with a young woman in her 20s who's experiencing some symptoms, can you just briefly explain what are those symptoms that women need to look out for?
yeah. So like I said, just remember 6 Ps: painful, irregular period, pain when urinating, pain when bowel movement, painful sexual intercourse, and difficulty getting pregnant. So if your GP is dismissing your symptom, just mention about how debilitated you are with the severity of pain and other symptoms. So if you're on a period and you're bleeding when passing urine, you're bleeding when opening your bowels, you're bleeding when having sexual intercourse, you won't believe even accident and emergency, so many patients are dismissed with symptoms of IBS. Two of my patients ended up having appendicectomy. One of my patient who suffers who is an intensive care neonatal nurse. She's a nurse. She was coughing out blood when she was bleeding, and they said, "Oh, stop smoking. Oh, it's all up there. Oh, she's back here again." But no, it was endometriotic deposits in her lungs. And I said, ask them to do a CT scan when you're on a period. So they did it, and there were endometriotic deposits on her lungs. And she had to go to London because there are no specialists here to get that treated. So there you are.
I think, speaking for myself and probably everyone else who's listening to this, I feel a little menopausal rage building inside me, because you just, I don't know, it's upsetting. It makes me feel angry that these are our daughters that are being ignored, our sisters that are being ignored, and in some cases our mothers. So it's, yeah, I mean, thank goodness that there are people like you out there challenging what has been considered the norm for so long. And you know, we all collectively, don't we, within women's health and the broader conversation, we just need to keep talking, and being quite forceful.
Yeah.
To get the solution and the support that women need.
Yeah.
Anita, thank you so much for your time. I feel like I've learned so much in such a short space of time. Quite emotional, actually, because I do know some women who've experienced endometriosis that are friends of mine that I've grown up with, that you know, probably don't even still know that it's endometriosis.
Yeah.
And that's quite horrifying to me.
It's
Anyway,
also
thank you.
reported, it's also reported after menopause, but then they are saying that it has developed before menopause because it's an estrogen dependent condition. So HRT and other things, you will have other speakers, they'll talk about it. Thank you. Thank you for
Oh,
inviting me. And if there are any questions, I'm always there. Thank you.
that's fantastic. Thank you so much, Anita.
Okay.
Wow. I'm not entirely sure how to sort of recover from that. I think we've just got to process that information, haven't we? And, you know, there's still a great deal to learn. I mean, I could talk to Anita for many, many hours on this, and I'm sure that we would only just be scratching the surface on it. It's such a topic of conversation, and maybe we hold another roundtable just specifically on endometriosis, perhaps later in the year. Okay. So, right, so that's one of our topics out in the open. We've still got a few more to go. And now I'm going to talk to Rona. And for those of you who are in our network, in our community, perhaps you are one of our menopause pros, perhaps you're one of our licensed menopause champions, you'll all know Rona. You would have had connection with her, conversations with her. I've known Rona now for some years, and she's been involved with Menopause Experts Group for, I think, 4 years now. Must be something like that, yeah. And of course, I know a bit about her, quite a lot about her personally as well as professionally. So I invited Rona to talk about what happened to her in 2005, in particular, when she was just 39, because although it's a rare condition that she experienced, I feel that there are too many rare conditions that women experience that never get seen or heard. And so, Rona, over to you, really. Let's have a chat about what you've experienced, and if you can just share that with us, and then what led to early menopause for you.
Thank you, Dee. And I just want to say, Anita, thank you. I like you say, Dee, I actually feel very emotional because it's highlighting, it's bringing up the gap in women's health care, in research, in respect, in dignity. And And that's not just relating to me. I think about my own mother, and, you know, Dee knows I've shared some of that background with her. And dismissed. And I think for me, what's really coming through and reiterated from what you've said, Anita, is the psychological impact, the life impact, the social impact. You talk about the financial impact of women having to remove themselves from what we would think of as normal opportunities as society, because we simply cannot function. And that makes me feel very sad, but very determined in equal measure. And so one of the things you wanted me to talk about, Dee, was in sharing my own experience of early menopause and what led that to happen for me. And so it's made me reflect again on all of this. And I actually think that I was in perimenopause in my early 30s originally, but I didn't realize. And I am 60 this year, so we're going back a number of years, and it just wasn't something that was talked about. It wasn't recognized back in those days, in the early sort of mid 1990s. And I know now, because of my education and my time with Meg, that, you know, in my early 30s, waking up with night sweats, drenched in sweat all round under breasts, around that whole area, that's not right. and it takes us back then to that early experience that so many of us do have, where thinking about back at school, very, very painful periods, missing periods, the impact on exams, and that's viewed as being normal. Let's just get on with it. And so, and then the heavy periods, the situation where you're out and about and you just think, oh, or somebody, what's that on the back on your skirt or your trousers? And so that, and the reason I'm mentioning that is because that becomes our normal, doesn't it? We know that as women, we just get on with it. We cope. We see it in our everyday lives, and those examples that we have. So our mother, our grandmothers, whoever, just getting on with things. And we really do need that to change, to be different, because it does impact on the rest of our lives. So for me, my sort of coming forwards to 2005, I went for cervical screening, as you do. And the nurse said, how long have you had that lump for? What lump? No idea. So it turned out I had a lump in the vulval area, which she thought was a Bartholin's cyst, which many of you will be aware of. Quite common, straightforward procedure to deal with. So got booked in for that, referral from the GP, only to wake up later on in the evening to discover that it hadn't been a Bartholin's cyst, and the surgeon hadn't been able to stop the bleeding, hadn't been able to get rid of nearly all of it. And so that led to further referrals, or the outcome being that I had something called an aggressive angiomyxoma of the vulva. And at that point, it had even only been given a name around 15 years before that. And when you look on the internet now, and it will be interesting to hear, Kavita and Anita, what your experience of this is, there's very little information. It is very rare. It's benign. It's aggressive. It's called aggressive because there is very much a tendency for it to recur, but usually will only recur once, and that did happen in my case. And because this is, and it occurs mostly in women, I believe, around about that sort of age, late 30s into 40s, does occur in men too, but not so often. And it's usually in that vulval or that pelvic area. And so for me, because of the stage that it had got to, that meant radical surgery to remove, so a hemivulvectomy. So I had the left part of my vulva pretty much completely removed. I was single at that point, getting on with my career, as so many of us do. I just always imagined I would have children. So we're going to talk about the impact on fertility of that early menopause and that type of surgery and potentially the reasons why. And so although this is very rare, I'm really pleased, Dee, that you asked me to talk about it, because it's not so much the condition, it's the impact of that type of condition. So I was fortunate to be treated by pretty much one of the foremost gynecological oncologists in the UK, and partly because it was so rare and because very complex. There were multidisciplinary meetings. I was assigned a cancer nurse. I went to do a lot of this on my own. And I think a lot of women will identify with this, that when it's not something you're used to talking about, or you maybe don't have a partner. I did have good friends who I did let in latterly, but I went through very much of this on my own, partly because of previous life events, meaning that I tended to just get on with things. There was talk of potentially reconstructive surgery, so a plastic surgeon was part of that multidisciplinary team. I wasn't really very prepared for much of that, in all honesty. And so had really quite major surgery that involved 2 anaesthetics in a very short space of time, general anaesthetics, because I'd had one previously for the Barthol and cyst investigation. And the psychological impact, it's significant. So facing quite significant disfiguration in that sensitive area, single, not a lot of family, no family around really to support. My elderly parents ended up coming to look after me because I couldn't do anything. Extreme pain, couldn't sit down, couldn't walk, and incredibly fatigued. And somehow over the next few months, life just continued. I had a really full-on job, travelled all around the UK, lots of long hours, far more focused on looking after everybody else and making sure that they were okay in my team and that I was delivering the workload. Had a new relationship. The disfiguration, the impact didn't really have an impact on that. Then just about the time that relationship broke up, the checkup showed that the aggressive angiomyxoma had returned. And the surgeon, the consultant, had been very careful to try to excise as much as possible, but not to disfigure, so not to be too drastic. And unfortunately, that meant that the potential for it to recur, it did reoccur. So I had to go through the same procedure again. And then a week later, discovered that it had got infected. So bleeding from there. My sister was with me, but my friends came and helped. I shouldn't have gone. I'd had the surgery the second time done privately, and partly because you just block all of this out, don't you? My instinct was to protect the work that had been done, because I knew how much attention he'd paid. The gynecologist had paid to making sure that things looked okay and I could still function well in that area. So I ended up with a blood transfusion and was told that I really nearly didn't make it through all of this. It was so significant. So the trauma, the psychological trauma of that's the impact. Is what I am led to believe from the gynecological oncologist at the time, is what led to my early menopause really being accelerated. So potentially I was already starting to go down that route, but the blood test showed that my follicle stimulating hormone, luteinizing hormone in that year from the first lot of surgery had dropped like a stone. And so from the fertility perspective, really, really drastic. In a new relationship, looking to have a family. And the psychological impact of that, of course, extremely significant. And having done more research now, so the gynecological oncologist had said to me that the connection was the impact of the surgery in that area on the pituitary gland. Now that is probably too literal. So Kavita and Anita, you know that actually in medical terms, that's not the case. And it's the research now shows that the psychological impact, that's where the connection is. And this is what I really want to focus on, is that understanding that, and so many of our champions identify with this, that significant life events. So I had a lot of trauma in my childhood, in my early adulthood, significant. And when that's not addressed, combined with such invasive surgery, the psychological impact, the fatigue. I was fatigued for, I could barely walk any distance for months. And if my now lovely husband hadn't been in a position, because he was retired, to be able to drive me to all the places I needed to go to for work, I would not have been able to do my job. I would have had to have left. So that, again, that impact. So I've talked quite a lot, Dee, and there might be something else that you want to ask while I take a breath.
No, and it's interesting. I mean, we know each other very well. We work with each other very closely, but we've never actually had this conversation, have we?
Because we don't, do we? We don't tend to talk about stuff like that. You and I might, but not in normal conversation, even between female friends, we don't really tend to talk about this, do we?
Yeah, and it's it's an interesting thing, the work that we do on a daily basis and the amount of people, women, that we talk to. I don't think a day goes by where we don't recognise a woman who's experienced significant trauma. I actually believe they probably don't exist, is what I'm starting to believe. And I think the impact of trauma, surgical trauma, and other trauma, as you say, you've experienced it from a very early age. We don't quite understand, and this is where more and more research is needed, we don't understand that connection to our later years, later in life, when we are experiencing menopause and into perimenopause, when we're actually going through that transition, which is often the worst time for many women. And the biggest symptom that we see that is crippling the world of menopause and these women is the psychological impact of an accumulation, I think, of things that have actually happened to them through life. And when they're then going through yet another hormonal shift, because let's face it, we don't just have one, do we? We have several. And in fact, we're blessed with them from age 11, 12, 13, these hormonal shifts on a monthly basis. We bleed for 7 years, is it? 7 years back to back. We're bleeding as women. That in itself, and how that starts for us as women, from our first menstrual cycle, how that happens and how that impacts, and the experience that we have when we first start bleeding is trauma at a very early age. Then we're looking at, those gynecological issues that we all have to address at some point. Something will happen to us at some point. There's this accumulation of trauma. So I kind of, now getting to know you even deeper, I can understand why. And of course, I know that, in your work life, you had a complete meltdown, further into menopause. So just tell us about that.
I am happy to talk about that, Dee, because I hear it from so many of our champions, and in my role, I also talk to people who are interested in what we do and becoming part of that. And there really is a theme where women get to a point where we are utterly broken. Just becomes too much. It all becomes too much. And that link between that hormone shift, that menopause, there's not much of a pause about it. That's so impactful. And that's why this conversation around the trauma, the life events that we all go through, the difficulties potentially in childhood, being bereaved very young, so do the story about my mum, which I know a lot of our champions identify with. She was 56 when she died and I was 20. And that's hugely impactful. And that then is often followed by many other events, significant events, and they are viewed as normal life events, and of course they are. But when we then add in other factors, such as losing another parent, so for me, just at the time where I left my corporate career, definitely due to perimenopause, early menopause, and that whole series of events, my dad died. Now he was 83, so and had a very good life. It was even more traumatic for me because I'd been so poorly. I just wasn't well enough to keep traveling from England to Scotland to be with him, to support him, and support the rest of the family. And so he died, and I left my 30+ year career the same week. And again, there's that impact. And so that may have been my choice to leave, but I felt that I didn't have an alternative. And so I would have been mid-40s, just sort of 46, 7 at that point. And I really feel quite cheated because there was no conversation about menopause at that point. There really wasn't. Going back to when would that be? 2016. Very little. And I saw myself go from what I would think of as being very capable, as many of us are, very senior account director, managing huge delivery teams all over the UK, thousands of people for blue chip clients, making a huge difference on a day-to-day basis to people's lives in the workplace, maintaining the blue light services for many of us around the country, being able to do all of that, talk to thousands of people in a room, to having to have somebody in front of me to go into a shop. And this is the real impact that we all feel, don't we? And so in terms of a career, that just almost went overnight because it just didn't feel possible. And the other aspect that I really find myself wanting to be very open about is that whilst our mission is, and absolutely has to be, that women feel safe talking about this at work and this being known at work about the significant impact, we need to recognise too that it can become a barrier. So I mentioned that in my earlier life, in my sort of 18, 19-year-old self, I would phone into work. I would be quite bullish about it. I would say, I am not pretending that something else is going on. I can't go to work because my periods are so bad. They're either so heavy or the pain is so debilitating. All these years later, did I want to say in the workplace, in that level of meeting with clients, that I need to excuse myself from the meeting, or I actually found it really difficult to get here this morning. I can't remember your name. Don't ask me to do any kind of on-the-spot negotiation, because that's just it's not possible. And so hopefully, Dee, that starting to open up this conversation here in this session will be helpful, because we really need to be. We really, really need to be aware. And when we look at, one of the things you asked me about was what's the most impactful. And I think that's the most impactful aspect of early menopause, combined with, of course, discovering that my fertility had just completely gone, when I always thought that I would have children. So those are hugely significant, and so many of us go through this, don't we?
Yeah, it's quite a journey, isn't it? And I think, we know that this is what drives us with the work that we do, because the more we feel we have others who understand us around us, the more we can be outspoken about topics like this without the fear, because we feel that there's another woman who's got our back. We know that this is going to be recorded and it's going to go up on YouTube. And so it could be viewed many times, and I hope it is. because I really hope that those women who are still in the shadows, you know, our work's not done, is it? It's not going to be done for decades and decades, long after we've gone. But that, you know, they're still in the shadows and still too frightened to talk about, because of shame. You know, shame has been so embedded into women's brains. The shame of, you know, periods being a dirty thing. And so from a very early age, most of us, and it really, I don't think it matters culturally. I actually think that it's just society around the world, that we are, you know, I hate to use the P word of patriarchy, but we feel it, and we feel it more and more the older we get, I think, because we're just experiencing more and more of life. And as women, we can just see where an awful lot of that trauma stems from. And even if you're going through a debilitating disease, or other health concerns, it's about the support that you have around you. It's how you are treated at the time of which you're experiencing trauma that has the greatest impact many, many decades later. And that's where things have to significantly improve in women's health. It's the women's health outcome that we all want years later, when we've experienced these sometimes horrific challenges in life. It's not that we experience it, it's how we experience it. And then it's the support that we have thereafter, which is lacking. And so it's I mean, I know you very well, and I sort of filled in all the gaps that you hadn't told me, and now I have all those gaps filled by you, and I feel very privileged to have listened to that story and the work that you do and that you and I do and we continue to do, and we've got great plans over the coming years. You might be turning 60 in October, but don't you ever think of retiring. That's not on the cards at all. We got way too much to do yet. But it's lovely to have your candor, Rona, and your strength actually, and your courage. And I know that you're going through, you know, all sorts of things even now, in your late 50s, you know, some mobility issues and issues with joints, and you're still being investigated. I know, but you know, I just do know that I wish you all the very best, and we've got perhaps the best years still to come once we can get to grips with all the grotty years beforehand.
Absolutely, and I think that's a really key message, isn't it? That whilst we must not sugarcoat and underplay what we all go through, there is a power, there's a strength in getting to this point and feeling like it's all coming together. And I think that's one of the things that drives me to really be supporting our global community. And it's the biggest message that I would send as well, that, you know, utilize all your experiences in life, acknowledge them, and keep fighting, because I do think sometimes it is a fight, isn't it, for dignity, respect, acknowledgement. And the main message is be aware of our own bodies, of every single aspect of our bodies, how it functions for us, what's not right, and be persistent.
I was so thrilled to see one of our champions, Petra, actually the other day. She's our champion in Gibraltar, and I don't know whether she's on the call actually today, but she was talking about, you know, what we have trained them to do, which is to check their vulval area, to get a mirror and have a look at what's down there. Because again, we've been taught as women that that's dirty down there, that we shouldn't be looking down there, that we shouldn't be touching down there. When actually, you know, we all know we have to examine our breasts. Okay, we all know, and hopefully if you're in the shower or in the bath on a daily basis, you're examining your breasts. Most of us don't know how to do it, but at least we're doing it. And we're going to be having a roundtable session on that another time. But we mustn't forget what can be life-threatening below the belt. we need to look at what's our normal down there. We politely call them fanny mirrors. Just get a mirror, or you can use your mobile phone. Just make sure you don't WhatsApp it to anybody, because that would just be, that would blow their minds, and you'll probably never see them again. But, just have a look at what you look like now, because it's only when you've got a base point that you can see if any changes are occurring. And it's the same with our breasts. It's the same with any part of our body. It's the same when we're looking at moles on our skin. We should know our bodies incredibly well as a map that we study. And the bits of our bodies that we can't study because we can't see them, then if there's somebody intimate in our lives, teach them how to study that map. It's really important. Most of us as women, if we're heterosexual women, and we have a man in our lives, we will be the ones that will find that mole. We will be the ones that will find something that's not quite right. We're often the ones that find the lump in the testicle. We've got to teach men to look out for their bodies as well. But as women, let's become our own advocates and just look at our own body and understand every single inch of it. Because that way if anything changes, and we can get to it quickly.
And that was going to be to say, before I say thank you for the opportunity, I really wanted to say that, because for me, that lump could have been not benign. It was really significant, but it could have been something else, and I had no idea. So I really did want to say that. We can joke about it, and we've got to see them. There's lots of fun. There's lots of funny stories associated with that period in my life, which are not for sharing on this session. But there's always a lot of humour in there that we find, isn't there? And I just wanted to say thank you, Dee, for it is an honour. It's been a privilege to share this with you today. And I'm so glad we're having this session, and also that we do what we do, and that I am so privileged to be involved and a part of this. So yeah.
Well, bless you. And it's my privilege. Indeed, I feel very privileged and honoured. Okay, that is Rona. Let's move on.
Found much more about me than you perhaps expected to.
Well, yes, quite. Yeah. I'll probably find a new nickname for you now as well. So over now to Kavita, who's been listening to all of this, haven't you, Kavita? I know it's been quite a whirlwind already, and yet we're saving PMOS, formerly PCOS, and then we'll touch on a little bit of surgical or medical menopause at the end. But Kavita Verma, I'm really delighted to introduce you to our audience. You're a consultant in obstetrics, I can never say that word, and gynecology, equally a word that I can never spell. You've picked the two really awkward words, haven't you, as a profession? 30 years plus of experience, and I know that across India and Nepal, and then your journey brought you to the UK. You've done your time in the NHS, I know that as well. We had a long conversation yesterday. And you have this extensive experience, as does Anita, around women's health, that includes endometriosis, fibroids, abnormal bleeding, bladder issues, contraception, early pregnancy care, and then we're talking about perimenopause, menopause. Goodness me, women, is there anything that we don't go through? I mean, honestly, that list could have been 100 times longer. It's just scratching the surface, isn't it? Now, I know that your passion is looking at premature menopause and what leads to medical or surgical menopause. But we're going to talk about, initially, we're going to talk about PCOS as we've all known it to be. And then this very recent change in the last week, actually, it's very, very recent, isn't it? Renaming it to PMOS. And I will leave the rest to you. We've got some questions to go through, but let's talk about this as a women's issue.
Thank you, Dee, and good morning, everyone. I hope you can hear me all right.
Yes, we can.
I just wanted to make a comment on Rona's his story. It just reminded me how very strongly the ovaries are linked with the brain, the hypothalamus, the higher centers. We get stressed and our ovaries completely switch off, and therein we experience the symptoms of perimenopause and those things. PCOS or PMOS, like endometriosis, it might be understood a bit better, but it is another condition where people don't put strong emphasis on it. We don't know how to deal with it. We don't know who should be dealing with it, primary care, secondary care, or even tertiary care. And there's so much issues around it. So just to rewind a little bit, PCOS, what we know used to be, it used to stand for polycystic ovarian syndrome. The incidence is usually 1 in 8, and we know that it affects women in the Southeast Asian countries more than in the Western population. And that could be a genetic reason as well. But we know women here are also affected by it. So until very recently, PCOS used to be used for the presence of cysts within the ovaries, along with other symptoms related to periods, such as irregular, scanty, or missed periods, and signs of androgen or testosterone excess, which is a male hormone, but it's also found in females as well. And women would be describing increased facial hair or increased body hair, and that terminology was called as hirsutism. They could have acne, oily skin, and a female pattern of increased hair loss. So, and that also together with fertility issues, that described PCOS in general. But PCOS, it placed more significance on the presence of cysts within the ovaries, as the name implies. And it was approached as if the syndrome was restricted to within the pelvis only. We now know that the ovaries don't have to show the presence of cysts in the ovaries for the diagnosis of PCOS or PMOS to be made. So when women were younger and presented with these symptoms, we just treated them with contraceptive pills to deal with the symptoms of fertility-inducing medications. And then we left it at that. Once they got pregnant, they got past that age, we just didn't know what to do with them. Clinicians did know that PCOS is associated with long-term health issues such as type 2 diabetes, but not much focus was placed on it. So especially we didn't know who was going to monitor these individuals, when they should be monitored, and how they should be monitored. So the new term PMOS, which has been introduced very recently by a team from Australia, from Monash University, it was led by Helen Teed and a team of other experts in it, and they changed the terminology to PMOS, which literally means Polyendocrine Metabolic Ovarian Syndrome. So you can see in this terminology, the cystic has been removed. So we don't rely on the cystic structure within the ovary. We do realize now that this syndrome is much more complex. It has broader metabolic implications. It affects several other systems within the body. So it is a multi-system disorder, really. And we know that these metabolic changes will persist throughout life until and unless addressed at the right time. So the term PMOS, it is much more descriptive of what the syndrome actually involves. So this change in language, I think, is really important, and it has come at the right time after a long time, but yes, it has come at the right time because it's going to enable individuals to receive lifelong monitoring through blood tests, through treatments, and it should be addressed by a team of expert specialists, which of course GPs are in the middle of it all because, it starts from there. But it involves endocrinologists, gynecologists, psychiatrists, and even sleep specialists. So that's why the change in terminology is so very important.
Yes, I can see. There's a bit of sort of jubilation out there, isn't there, about this change, because it is going to support women further and perhaps get diagnosis sooner, which, as we know with endometriosis, is crucial, right? So that getting the diagnosis early with these complex clinical issues, then the outcome is going to be hopefully better. And as I was saying about, it's not what you experience, it's how you experience it, and the support that you get, and the broader treatments that are open to you. So I can see a really good positive move in the right direction. And if nothing else, PMOS has been brought to headline attention, which of course is never the case, right? Like endometriosis, we've brought menopause to headline. It's on mainstream TV, and women are talking about it. Celebrities are opening up about it, and we've managed to do that as women, which is great. But there are all these, I call them almost sort of tendrils now, that are going out, which is again why we've created this round table, so that we can talk about all of these other touch areas that actually impact menopause. And there's, forgive me if I'm wrong, but I think I'm right, there's a big crossover between PMOS and endometriosis. And so they're quite often experiencing both.
You're right, because women with PMOS, they've quite frequently found to have endometriosis as well. And I recall from my younger days when girls came in with signs and symptoms of PCOS, and they said they've got pain. And we thought, well, many of us used to tell them, well, PCOS is not associated with pain. So it's something else. It could be IBS, or, it could be something else. It wasn't really very well understood. But we now know that there's a strong association. So there could be coexistence of endometriosis at the same time.
So can you let us know, if you do know, and if you don't know, then no one knows, what causes it?
Well, we don't really know what causes it, but there are various things which are happening inside the body, which is leading small ovaries, big problems. I think everything lies within the ovaries. So there are lots of changes, metabolic changes happening inside the body. So to start off with, there is androgen excess in the body in women with PMOS. I'm going to call it PMOS now. And the ovaries, they've got tissues which fail to respond and fail to ovulate. So once the eggs are released from the body, progesterone comes into play. So what is happening with the ovaries, that they are not ovulating, so they're not producing the right quantity of hormones at the right time. In fact, they're producing a lot of androgens, which are causing all the symptoms. And then the body is not responding to insulin in a proper way. So there is insulin excess inside the body, or rather insulin resistance. So the insulin is not responding to rises in blood sugar levels. So there is insulin resistance, there's increase in blood sugar levels, and there's hyperinsulinism. So the pancreas are working harder to produce more and more insulin to digest this sugar. And initially it copes in the younger age group, but later on it doesn't cope. And then the cells begin to burn out and results in type 2 diabetes and all the metabolic changes with time. So, but basically we see a lot of hormonal changes which are thought to be the cause of this. And genetics does play a role in this.
And so does it, oh, right. So on the genetics front then, so if your mother experienced it, now let's talk about fertility, because of course, if there's fertility issues and there's a high prevalence of infertility, then your mother is unlikely to have experienced it, right? Because she was unlikely to have children. So what are the statistics around that? So if you've been diagnosed with PMOS, then what are the statistics around going into early menopause, and therefore having to negotiate all the emotional and mental anguish of infertility if you were expecting, like Rona, expecting to have children? So what are the stats there? What are they telling us? Are they saying, and with that interlink with endometriosis as well, I'm assuming that you have a higher incidence of infertility, but is that always the case?
Well, with PCOS, it's not always the case. But yes, it can be associated with fertility issues because, as I said, the ovaries are not ovulating, they're not releasing the egg. There are ways and means by which the ovaries can be stimulated to release an egg. There are medical methods, there are surgical methods, so that can happen and it can be difficult. Whereas, as I understand with endometriosis, it's quite difficult. If you've got endometriosis, you may have a higher chance of having fertility issues. With PCOS, we can kind of deal with it and it can be successful. I cannot give you the percentage, but I think it's quite successful. With regard to your other question, that does it produce menopause earlier? No, it doesn't. So women with PCOS and PMOS will experience menopause at about the same time, which is about the age of 51 or so.
Ah, that's interesting. That's
And
interesting.
you talked about, sorry, you talked about genetic things. Yes, we know that girls who've got PCOS, they might have received the genes from their parents, and their fathers and brothers might be having the genes as well. So it is kind of connected in that way.
Ah, so the gene can be, so the gene, it can come via the male. Yeah. Yeah. It's a really interesting conversation. And again, like endometriosis, it seems like we're talking about this more and more. And why are we talking about it? It's because lots of women are coming forward now and talking about their own stories, and with social media the way that it is, and people having that platform to talk about women's health in this way. Where do you see it going? I mean, are there trials, research? What's happening in that world that gives us hope, that we can see for future generations? Is it going to get better, or do you think it's going to get significantly worse?
I think more trials are underway because people need to realize that there could be more phenotypes related with PCOS. And so more trials, more study, more research needs to be underway. And I think a lot of it is still happening. But at least there is light at the end of the tunnel. We do recognize what PMOS is about, how, what sort of treatment and support the women need during the earlier days, especially a diagnosis. So it's very important they get a diagnosis. So many women do not even get a diagnosis that they've got PMOS. They start off with irregular periods, they miss a period, they've got several months of missed period, and they are not aware that they've got PMOS and that they should address that issue. So at least the awareness, this is going to help increase the awareness that if you've got this triad of symptoms, you should get that checked, you should get that sorted, because it's got long-term health implications. So there could be lots of metabolic issues related with PMOS, which, if addressed at the right time, it's going to improve your quality of life. Like previous speakers, Anita and Rona, both have been mentioning, the quality of life is so important. So if the quality of life at this stage is not addressed, and women are not aware that this is what they should be aiming for, these are the tests they should be doing, these are the investigations they should be going through, and these are the medications they should be, would improve the quality of life. So this is what people should be aware of. And of course, we do need a lot of research into this as well, because though it is understood, we don't really know what's the best cure. We kind of treat it or address it as head on, but we don't really know what's the best option. So it's not like one thing addresses or treats all. You have to try and treat one with something and then with another and see if that works or if that fits.
And I'm guessing that it's only going to be more research that allows us a window into prevention.
Mm-hmm. Yeah.
When we were talking yesterday, I was talking to you about, having this preventative attitude, which they have in France, which, I spend a lot of time in. And I think it's so important. I mean, I can see the links and certainly how women's health has changed over the last 40 or 50 years. And we can see that with our mothers and our grandmothers. We can see what's changed, or how it's changed, and how our bodies and how we how we find solutions and what we experience has all changed, but so has our lifestyle, so has our environment. How we live as women is significantly different to how we lived as women 50 years ago. And so, we were talking yesterday about diet, for example. Our diets are hugely different now than they were 50 years ago, when we were eating much more fresh produce, and we would go shopping on a daily basis because it was fresh, and you would eat it on the day, and then you go back, to your grocers, or you go back to the bakers, or you go back, and we were eating things that were chemical free. So I have this bee in my bonnet, which those who know me know. I have this bee in my bonnet about the chemicals and the toxicity that's going into our bodies, that have been going into our bodies for decades. Okay, so there's this chemical buildup, I think, of toxicity. And although we're seeing young women, Anita was saying that sort of average age of diagnosis of endometriosis being 27. So these are young women in the prime of their lives, in the prime of fertility, as we would expect, that are experiencing more and more fertility challenges because of these clinical issues and disease, infection, inflammation, all of those sorts of things. Surely we need to be having further conversations as clinicians and non-clinicians about the toxins that we are exposed to, because I'm sure there's a link.
I agree totally, because one of the first steps of facing PCOS and advising, PMOS women is lifestyle changes. So the first step is and it's really difficult. You tell these women you're overweight, things will be better if you reduce your weight. Little do we realize how very difficult it is for these women to reduce their weight, because they've got so much insulin resistance, so much androgens in the body, and these two things are contributing to the weight gain. But having said that, lifestyle changes with plenty of physical exercise, and especially weight-bearing exercise, is really important for them to improve the strength of the bones and muscles in future. But also things like Mediterranean diets, and I'm not an expert on diet, but Mediterranean diets with low glycemic index, plenty of fresh fruits and vegetables, all these are really helpful to start off with.
Yeah,
so I agree totally. Lifestyle changes is really the key.
And I think being kinder to us all, really. If we're holding on to a bit of extra weight, to be kinder to those women, to remove that shame, because actually women, it's not their fault if they're overweight. I don't think it's anyone's fault if they're overweight. I actually don't believe that
I agree.
there is a finger wagging here blaming people. I don't believe it's their fault, because even if they're sitting and overeating in front of the TV, culture, society has moved them in that direction. They've not actually chosen that. You've kind of been led. We've been led into certain circumstances and eating habits and lifestyle traits.
There are other things which we lack, is actually what I experienced as a young doctor. We had a team of specialists which would advise the women, a dietitian basically. All those things have been removed. So essentially, I do not want to say what's in the NHS, what's not in the NHS, but the guidance is not there. The women have to go and search for it themselves, which is all right. But it's really hard to do something without proper guidance in place.
Yes, I think the power of influence is what we need. We need influence rather than to be told what to do. None of us like to be told what to do. None of us like to have our failings pointed out to us. We don't. But I think that there's so many things missing to positively influence our lifestyle and our diet. And notwithstanding that, we are women, and if we're women with families, we put ourselves last anyway. So even when you're trying to influence a woman to get out and walk more, eat more vegetables, reduce your weight, you do some weight bearing exercises, do some weight training. You can say all these things to women until you're blue in the face. But actually, if she's got no time for herself, she's never going to be able to pick up that weight or go walking every day, because there's always going to be something else or someone else pulling on her resources. And so that's what we do as champions, really, is we just want to let women know that, look, we're not pointing the finger at you. We're not saying you're failing. You're not failing. You just don't have the right support around you to encourage you and influence.
Mm-hmm. Yeah.
So it's a really fascinating conversation with PMOS, and I'll forever call it PMOS now, not PMOS. So see something else I've learned today, champions. We've got to get on board with this. We all thought it was PCOS, but it's PCOS. So thank you for that, Kavita, for teaching us the right pronunciation. Now let's just touch on medical and surgical menopause, and I wanted to add this in because of your experience and that vast knowledge that you have. It would be remiss of me to not use the time to tap into your brain. Medical menopause versus surgical menopause. Of course, our champions will be aware of this through the training, that some of that will be brought on by disease and illness, and then surgical, of course, is having your ovaries removed. Huge impact on the body, and sometimes can be sudden, overnight. And I've had lots of conversations with women who have had radical hysterectomies, and they've never even had a conversation with anybody about what happens next. That's unfortunately more common than perhaps we like to admit. But let's just touch on that. So in your clinical terms, in your view, what is the difference between the two? And does that have an impact on long-term, what impact does that have on long-term health?
Yeah. So a natural menopause is when someone achieves it at the right age, around the age of 51 in the UK. And that is preceded by several years of declining hormones, and that's called the perimenopause. So with a natural menopause, the body has got time to adjust to these falling levels of hormones, and the body adapts itself in that way. So symptoms may or may not occur, but they occur in a progressive, slow way, so don't come on suddenly. And with the natural menopause, people can address it with lifestyle changes, dietary changes, physical exercise, and HRT if needed. So that suddenly don't feel, I've got all these massive symptoms and they've all come on suddenly. But with a surgical and medical menopause, where in the surgical menopause, the ovaries are removed at any type of surgery. I'm not going to discuss this type of surgery. And with medical menopause, there are treatments such as chemotherapy and radiotherapy, etc. The change in the hormones in the body is sudden. So with the surgical menopause, the ovaries are removed. So the women can experience the symptoms suddenly, strongly, abruptly, within a few days or immediately after surgery. So I've had women wake up from surgery and in 2 hours, they're flushing and sweating so much, and they're not sure what's going on. It's because we've removed the ovaries. And we also know that ovaries have got, together with estrogen, they've got testosterone, which is such an important hormone in the body. We now call it as a female hormone. It's not a male hormone anymore. We call it as a female hormone because it's got such useful effects in the body. So we've literally, pardon me if I use the word, we've castrated the lady. So we've removed the ovaries. And so the impact of this loss of hormones is immediate, sudden, and severe. Similarly, with the medical treatment as well, which can be for cancers, which can be for benign conditions, the onset is sudden, severe. With the surgical menopause, there's no reversal. With the medical, there may be reversal if the chemotherapy is not, it's not very high, or radiation is not very high. But because women undergo surgical and medical menopause when they are younger, treatments when they are younger, they are going to be, in a longer period of hormone deprivation. And that, if it is not replaced, that's going to lead to long-term effects. And long-term effects on the heart, the brain, the bones is so significant.
Yes, that's our next roundtable topic of conversation, is the impact of the big three, as I like to call it.
Yeah.
Yeah, it's again, when we're just talking about trauma, and talking about Rona's surgery, you know, having a radical hysterectomy and having everything removed is a huge trauma to the body, let alone the brain.
Yes. Yeah.
And I think quite often there can be inadvertently a lack of support, ongoing support post hysterectomy. And I'm hearing and seeing this. I think this has happened forever, and certainly, you know, for decades. I remember my mother having a hysterectomy, and she was in her early 40s, and she wouldn't have never had a conversation with anybody about how that would have impacted her life, health, well-being. She would have been completely oblivious to it. And of course, we know that a generation that are now, you know, almost past, but that generation so stoic and just really would have not spoken to anybody about anything that they would have experienced in terms of symptoms. I mean, I remember my mother, even when I was very young, I remember my mother drenched in sweat, and she would not have known why at all. And so I suppose what I'm getting at is, I think that there needs to be extra support, don't you, post surgery, you know, once they've left the hospital, you know, in the home, because we're sort of typically told, you know, 6 to 8 weeks recovery. Don't drive a car. Don't do all of these things. Don't pick up heavy things and all of that. So we're kind of taught about, and I haven't had a hysterectomy. This is just from listening to other people's stories, but we're taught about how to recover from surgery, but we're never actually taught how to recover mentally, psychologically, emotionally from surgery, and then how that's going to impact long term. And I tell you, the other reason why I want to bring this up is that very often we will talk to women who are in their 60s, mid 60s perhaps, who think that they have been there, done that, done menopause, it's over now, you know, I don't need to be educated on it. And it's only when we have the conversation about, but actually, tell me about what happened to you. Do you know the significance of this on your bones, brain, and heart? Of which the answer will be no, because they would never have been educated on it, or had a conversation about that. This is really significant, isn't it, Kavita? I think for long-term health.
Yes. I recall when women used to have a hysterectomy for a benign reason, and we would consent them and we would say, what about the ovaries? And the women would say, take it all out. I don't need it anymore. I've done that, my childbearing, and, take everything out within the pelvis if you can. And now we're telling them, just retain those ovaries because they're the most important organs in your body, in my opinion, at least. I think they are the most important endocrine system of the body, giving you the hormones, which is going to, make you feel better, make you feel stronger. And so I think it has started to happen, maybe not a lot, but yes, people are aware that ovaries are important and we should not be removing them willy-nilly at every surgery. We should try and conserve it as much as possible. So that conversation is happening. Don't remove the ovaries. There's only 1% chance of ovarian cancer if you leave them behind. And that chance is really, really small compared to what you're going to go through if you remove the ovaries. And of course, before any surgery, I think there should be a conversation. Is removal of the ovaries mandatory? Is it really that we should do it? If we do it, what is next? What's going to follow for you in the aftermath of surgery? And in my practice, I replace the hormone straight away. So when you've removed the womb and the ovary, you need to give them only estrogen, which is the feel-good hormone. So that's a better form of HRT. Of course, if you've left the womb behind, you have to give them both. But you have to have this conversation. You will need HRT for your health. It's safe. What are the risks? What are the benefits? And of course, we need to know the family history and all that sort of thing to see whether it's safe or not. So it's really important to have that conversation with this person who's undergoing surgery. I'm just going to tell you a very small incident from a very, very long ago when I just was born in the UK in 2020. And I was working in a hospital down in London. And this lady had a hysterectomy and removal of both ovaries. She was quite young, might have been early 30s, and she used to keep coming back saying all sorts of symptoms. And one of the things which I recall is my vagina is flopping. It's, moving. And we used to say, why is it doing that? And I would send that patient to the consultant and he would send her back to me because he hadn't a clue and I hadn't a clue and no one had a clue. But now thinking back, I realized she needed hormones. She was having a psychological breakdown without these estrogen, progesterone, and androgens. So these are the things we really need to be careful about.
I think we're just walking, talking hormones, aren't we?
Yes.
We can't live without our hormones, and these significant conversations around hormones, like we've talked about the heart previously, we need to be talking about hormones, I think, much more often, and all of them, not just those that feature in fertility.
Absolutely correct. I mean, I say you wouldn't remove your thyroid, would you, for something? So why would you remove your ovary if it's benign?
Yes, don't get me started on thyroid though, because I think there's way too many thyroids being removed at the moment. I'm trying to resist having my thyroid removed for exactly those reasons. I think if you're well educated and you kind of understand what hormones do, and the women who would have said, just take everything, take my ovaries, asking that question to a woman who's been going through extreme pain. Sort of like chop my legs off, chop my arms off. I don't care. When you're in pain, you'll just say, just get rid of it, just get it out. And so I think that's where I suppose if it's emergency surgery, you don't have time to have long conversations. But I think that consultation with a patient leading up to surgery, I think is crucial. It's crucial for us. Most of us as women, we would prefer to know, what am I dealing with here? Because we're incredibly resourceful, aren't we? We're resourceful as women.
Patient information, because that's what it boils down to. They should have all the information before and after.
Yeah. Oh, well, it's just been such a mind-blowing round table, this session. I'm sure everybody else will agree, and I'm so grateful to all of you for your time. I know you're busy people, making the world a better place, and so it's just been so lovely to have your company. It's never a chore to talk to experienced professionals, especially clinicians. I don't come from a clinical background myself, but that connection between mind, body, and soul, and that everything is connected. And it's time that we started looking at at women as from the top of our heads to the tip of our toes, rather than in pieces, which I think is often what happens, isn't it? We're just kind of looking at various bits of women's anatomy and physiology, when actually the thigh bone is connected to the knee bone. Everything is connected, and so it's great for us all to get together and just talk about what's happening in women's health. So I applaud you all for what you're doing, and thank you so much for your time. Now, I think Anita's gone off because she had another appointment. So last words from you then, Kavita. What message would you like to convey out there to women, especially young women who might be thinking that there's something wrong? What would you suggest or recommend that they do?
So I would suggest, firstly, they should be informed and they should do a little bit of background search. And they should not be worried about approaching their family doctors and asking for a referral if they need one. They should be kind of asking for it, if not stressing that they need this to be done. Excuse me. With PMOS, they should understand that they need regular screening throughout life. It's a condition which is not going to improve. It's not going to be cured, but it can be treated and managed. So they should kind of be aware of that. And they should ask for things to be done for them. With regards to menopause and perimenopause, of course, again, they should feel empowered to ask for replacement therapy if they need it.
Thank you, Kavita. That's wonderful. Now just going over to Rona, last words from you. Well, I know it won't be your last words today because I'm sure we're going to speak a million times over the course of today. But what are your last words and reflections then on this round table? You're on mute. Yeah, she always does this.
I always do this, don't I? Jumping straight in. Woo! I think for healthcare professionals, and I loved, thank you, Kavita, that you said it's a good reminder of the impact, the link between the brain and the ovaries and the reproductive system. And so I think for me, it's very much about just, and picking up on your point, Dee, and there's not a deliberate, I don't think there's a deliberate intention ever to create a disconnect and therefore further trauma for women going through something like this. But I think, unfortunately, that can be the outcome. So in my case, there was just no consideration at all given to the longer term impact of what had happened to me from that surgery. And I think from business, the perspective of business, recognition that all of these are real and that when women are going through these conditions, these experiences, we are not seeking pity. It's recognition, acknowledgement, and reasonable adjustments, which Anita mentioned as well. That, you know, we are in 2026 and much of this is doable. And where it is more challenging, and thinking back to my own career, service delivery, multidisciplinary teams, engineers, cleaning staff, grounds maintenance, and a service to deliver to clients, we've got to start thinking outside the box so that we can maintain those services in a respectful and a dignified way. And to women, just exactly that. Please be persistent, know your own bodies, know what feels right for you, and don't be isolated and don't be fearful.
Thank you. Yeah, that's great. Now, the next roundtable, we're talking about the big three, brains, bones, and heart. I had to think of them. What was the third one? Brains, bone, and heart, which will be really interesting, and that's on June the 30th. If you've really loved this conversation, then please subscribe to the YouTube channel. Let's get this out there, and then you can all start sharing it with women in your networks and in your circle. It's been an absolute joy this morning to talk to everybody and just listen to your stories, your advice, and your skill and experience. We must always listen to these clinicians who have been doing this for decades because they've seen change. They will have heard everything, seen pretty much everything, and we really need to tap into their knowledge, and that's what the roundtable is all about. So I'll bid you farewell. Thank you so much for your company, everybody. Thank you to our guest speakers, and we'll see you again on the next roundtable.